Hello, I'm Dr. Swati Naik and welcome on MQR AICOG TV. I'm pleased to have with me none other than Dr. Amit Patki. He's a medical director at Fertility Association Mumbai and he's also Honorary Secretary General of ESAG. Thanks a lot, sir, for joining us on MQR AICOG TV. We are going to have a conversation with sir on the topic of PCOS. So may I ask you the first question that do you agree that the PCOS in our country is on a rise?
Yes, it is, and there are two aspects to it. One is that the incidence of PCOS is increasing because of lifestyle disorders, and the second is the awareness is also getting better, and people are coming forward now to get themselves diagnosed and treated. Why PCOS is important for us is because it is the most common endocrine dysfunction in the reproductive age between 18 and 40. We know that almost 15% of our patients who come to us for fertility care are suffering from PCOS. And we know that PCOS not only affects adolescent and young women, but PCOS who are not treated would land up with severe problems, which is called as metabolic X syndrome, which is inclusive of hypertension, cardiovascular diseases, and hence it is important that we pick up these women, we increase the awareness of PCOS, we guide them from adolescence so that they can take care of themselves.
Right. So I think it's no more a disease of just a reproductive organs, but it's a disease which has gone beyond and affecting the other organs as well.
Absolutely. And the PCOS, one thing about PCOS is it has got different arms. One is obesity, and this can be tackled effectively with lifestyle modifications. We know that women who lose 10% of their body weight have almost a 30% spontaneous rate of ovulation.
Oh, that's really nice.
And 20% of them conceive spontaneously.
Oh, wow.
We also know that women who lose 10% of their weight, their incidence of hyperinsulinemia, their incidence of hyperandrogenemia can come down. And that is why these women, in addition to lifestyle modifications, in addition to talking to them about weight loss, we also can treat them with a variety of drugs now that are available, including use of metformin, myo-inositol and myo-inositol in combination with D-chiroinositol in a ratio of 40:1. We know that obesity is not hereditary, but it doesn't run in families. But as I often tell my patients, that nobody runs in the family. So it's a disease which affects the whole family, and that is why it is important that we increase the awareness amongst their mothers, we increase the awareness amongst their colleagues, because PCOS can sometimes give a lot of amount of depression to these young girls because of low self-esteem, low body image, and the irregular menses that they suffer from.
Right. So when we are talking about a PCOS and its infertility association, how do you manage such patients? Like, what's your protocol? Do you directly go for an IVF, or you just give a trial of normal conception followed by an IUI? And it's a stepwise approach that you will follow.
So for PCOS, as I said, lifestyle modifications to encourage them for diet, exercise, even a simple walking of 45 minutes will greatly help them in the long run. If only lifestyle modification is not going to work, we can put them on some pharmacological agents like metformin, or as I said, on some drugs like myo and D-chiro. There are very good ovulation induction agents which are available, like clomiphene citrate, or even the aromatase inhibitors, letrozole, which gives you very good success as far as ovulation induction is concerned. Frankly, 70% of women with PCOS can be managed with only looking after their lifestyle and maybe some mild drugs. Only a very small percentage of PCOS will need gonadotrophins to be given in IUI, or even very small, around 15% of them will eventually land up for advanced techniques like IVF or ICSI.
Sir, it is said that for a IVF patient, IVF protocol in a PCOS patient, one needs to follow a soft protocol. otherwise they may land up in a hyperresponders. Is that true, sir?
Absolutely. So, wherein hyperstimulation is something that we have to be very, very careful, and at all means we must ensure that the patient doesn't land up with hyperstimulation. And another thing is the patient doesn't land up with multiple pregnancies.
Absolutely.
To ensure that, we can now do a serum AMH blood test, which is an anti-Mullerian hormone. And PCOS who have got very high AMHs, we know that they have a very, very high risk of hyperstimulation. And these patients, when they are for ART treatment, we use the antagon treatment, which is a short protocol treatment. Patients who are also on the long protocol and in whom we find that they have a high risk of hyperstimulation, be it the long or the short protocol, we can nowadays freeze all technique. Very good vitrification rates are available. So cryopreservation of embryos is something that we can do, and we can then transfer these embryos in some natural cycle, maybe a few months later.
So it's better to avoid in the same cycle, especially in such patients.
Absolutely.
Right. Because I think I would like to ask you one important question about OHSS, sir. How common is it, and how many cases you have come across such serious OHSS?
Okay. Now the incidence of severe OHSS is not more than 1%, but it is important that you pick up these patients, and more important than that is that you counsel patients that this can happen. In any patient who is undergoing stimulation with gonadotrophins, there is an inherent chance that she can hyperstimulate. But I think very strict vigilance by transvaginal sonography monitoring, and in high risk patients to do their estradiol levels will help you to pick up these patients. And you can, in an antagon cycle, nowadays give them a GnRH agonist as trigger, which will virtually eliminate your risk of hyperstimulation. The other drug that you can use is cabergoline, which can be given for a week from the day of trigger or from the day of oocyte retrieval. And in my practice, this drug has remarkably changed the incidence of hyperstimulation, and we routinely now give it to professional donors so that they do not hyperstimulate.
That's really nice.
But in the event that some patient may hyperstimulate, because this doesn't remove the chance completely, it reduces the chances, you have to treat them vigorously by putting them on low molecular weight heparin, by ensuring that they are well hydrated, and in some patients you may have to do ascitic or pleural tapping, the severe OHSS. But hyperstimulation can be managed with very simple pulse rate and by doing a CBC, so you don't need any major investigations. If the pulse is more than 120, you have a case of severe hyperstimulation. Or if the CBC shows you hemoconcentration with increased platelets and increased PCV more than 45, you can suspect that this patient has severe hyperstimulation.
Absolutely. Thanks, sir, for sharing those very important in-clinic tips. So we can say that it's a antagonist protocol with a GnRH agonist trigger that would help to your patients. Along with that, a cabergoline is coming as a rescue for such OHSS patient. Sir, in terms of ovulation induction, does letrozole has an upper age as compared to clomiphene in PCOS particularly patients?
Yeah, till few years back, clomiphene citrate was the only drug that was licensed for use. But nowadays, with the availability of aromatase inhibitors, particularly letrozole, we can now get monofollicular development. The letrozole half-life is short, so you can use it back to back, and its anti-estrogenic effects on the uterine endometrium is also less severe than clomiphene. So letrozole, I think, will now be the mainstay of treatment for oral drugs of ovulation induction.
Absolutely. Thank you so much, sir, sharing your views on PCOS and fertility. My last question would be, we very well know about PCOS and it's in the adolescent age as well as in the childbearing age group. Very little is known or very little is researched on the aspect of PCOS in the elderly woman or a perimenopausal or the menopausal woman. Does it really affect to that age group woman, and how to deal with it?
I think that's a very good question, because often what happens is once a patient with PCOS conceives and has a children, the
Yeah.
doctor and the patient both forget that they need to be monitored.
Right.
It is extremely important because PCOS is one of the main reasons for occurrence of metabolic X syndrome, which
Absolutely.
means the patient has got hypertension, type 2 diabetes, and fibrinolytic changes, which predisposes her to cardiovascular and even neurological strokes. So such patients should be advised and should be routinely assessed to make sure that their blood sugars are normal, their lipid profile is normal. It is worth putting these patients on long term of insulin sensitizers, be it metformin, be it myoinositol. These patients will also do well with statins. These patients do well with acarbose, which is a drug which
Postprandial.
inhibits,
Postprandial.
postprandial,
Postprandial
which
glycemia.
will decrease their intake of glucose. And such patients, as I said, the lifestyle is something which should remain with them for the rest of their life. So I often tell patients that don't leave your walks, your diet, and your exercise, because this will prevent you from getting diabetes, will prevent you getting hypertension at an earlier age. So it is
Absolutely.
extremely important that these patients need to be kept under surveillance.
Absolutely. So I think after discussing with you, we can say that PCOS is also climbing its ladder to come into the lifestyle diseases the way we are worried about hypertension and diabetes. PCOS is no more a reproductive age disease. It's coming
Absolutely.
across the spectrum of a woman's life. I think we should be taking those clues from your important views on the PCOS and its management. Thank you very much, sir, for joining us